it's unbelievable what you can see now with the laser technology. Things are much more precise when you're applying a laser platform. Now, whether you're making a cut on the cornea, it's principally the same thing, right? So lower energy is the key thing. If the surgeon feels confident, I can get the lenticle exactly where I want, and doing this not just for 5 patients,
Right.
into every single patient that basically has the clear software on the laser in every center.
Hi everyone, I am Dr. Prakhyat Roop. I work as a cataract, cornea and refractive surgeon at Acura Vision Clinics, Roop Netralaya, Meerut. And today I have a very special guest with me. On this podcast we have Professor Jod Mehta. He is the chairman of the Singapore National Eye Center. The Singapore National Eye Center, if I would define it in one line, is the one-stop place where I would go searching for all my questions in ophthalmology right now. Their research, their clinical work is impeccable, and it impacts the practice patterns across the globe. And he heads the research and academics and clinical work that happens in that place. The reason I admire him the most is because what he does in his clinical practice is something that I aspire to do as I gain more experience and further in my career. So basically, he is the role model of all the people that I'm going to discuss today in the podcast or in the subsequent series in the podcast. He is the one person that I admire the most because he does corneal surgeries, he does cataracts, he does refractive surgeries, and he does them seamlessly and knows in and out everything about the anatomy, the physiology, and whatever changes we do in that anatomy and physiology in our ophthalmology. So thank you so much, sir. It's a great honor to be talking to you and discussing with you all these things about refractive surgery and femtosecond lasers. To begin with, I want to ask you, what all applications do you do with a femtosecond laser, the Ziemer Z8?
Great, thanks, Roop. So it's very nice to be here for this discussion. Thank you for that very kind introduction as well. So I think that, laser technology, we're lucky in ophthalmology because we like gadgets and we like imaging, and that sort of pertains to all of us when we're basically going through their training. And I think that, femtosecond lasers came around in 2003, 2004. And I can tell you that I do not think that in 2005, when I was a fellow in London, I could not have imagined what we do today, 20 years ago, that we could have thought is possible, because it's unbelievable what you can see now with the laser technology. And that, of course, initially lasers came around mainly in refractive surgery. So at the early days, I was mainly using it for basically flap creation for obviously LASIK. LASIK refractive surgery is one of the most common refractive procedures across the world in any subspecialty, probably number 2 to cataract surgery. And then over the years, as technology has advanced, we've seen now the laser platforms also basically develop to go beyond just refractive surgery. Cataract is the most obvious. Then over the years, as you know, we then developed ocular surface protocols that we use for basic tuition surgery, and now we basically have protocols that we use for transplantation as well. And to think that you can do this all from one unit is quite staggering, because the underpinning technology is the same, but of course the software, the applications, and where we use it for is obviously completely different, but it's all coming from the same machine.
So when we talk about the machine and its improvements, I think the Ziemer platform is something that you've been very well aware of. You know the science behind it, you know it in greater detail than probably any other clinician. So you kind of bridge for us the gap for understanding the technology. You interpret it for us in a clinician's perspective. Today I want to ask you, how would you define or describe it to a general patient? Like difference between the femtosecond lasers that were there initially and the femtosecond laser that is the Z8. So What's the difference?
So I think fundamentally the main difference back when the lasers were being produced and we started using the Ziemer platform, not with the Z8 but with the Z6 initially back in 2013.
Yes.
And the fundamental difference was lower energy. Okay, and that's a fundamental difference between higher and basically lower energy. And I think that for people to understand that as a concept is really important, because most of us are aware that generally with lower energy, we think that's familiar because there's less collateral damage, as a lot of Americans will basically say, right? And that's because obviously things are much more precise when you're applying a laser platform. Now, whether you're making a cut on the cornea or applying the laser on the skin, it's principally the same thing, right? So lower energy is the key thing itself. And I think that's one thing that's really different from the lasers. And that really was obvious back in 2011, 2012. But I can tell you that, you have to, that's a physics answer. Yeah. And of course, everybody wants proof, right? Yeah. So, you can say that, oh yeah, what's the evidence? And the thing is you see, is that unless you can prove that in a biological system or in the human body or in an eye itself, as a patient, you say, okay, fine, it sounds really nice, it's lower energy itself, but how does that make a difference to me as an individual? So I think one of the fundamental papers that we did back in 2014 was to really show the advantage that we could make a lamellar cut, a flap cut in a cornea, and without actually killing any of the cells that we could pick up with the staining. And that showed for the first time the concept of low energy actually is really translatable into a biological situation. And then most people will understand, right? You basically have something that's low energy, less power. I'm not going to get sort of burnt, or I'm not going to get side effects from there itself. And to me, that's a really fundamental approach to understand. And then from there, you can then build on all the other applications that are available with the machine.
So, that's what I said in the introduction, that when you say something, you actually work at the very basic biological level and do the research and prove it to us, for us clinicians, to actually understand and believe that this thing, which is theoretically physics, is translating into biology. And that beautiful paper is something which influenced me a lot, and in fact helped me decide which femtosecond laser platform I am going to choose for my practice. And that's how I actually landed up at the Z8. So thank you for that. Now, when we talk about the femtosecond lasers and the Z8, the question comes about automation. Why is there a need for automation? You are a prolific surgeon. You are great with cataract surgery. You are a great surgeon with microkeratome LASIK, I'm sure. And you are a great cornea surgeon. I think there are not many in the cornea world that know anybody doing better surgeries than you. So why did you need automation? How does it help you?
Yeah. So one thing so as you get older, you realize that in your whole lifetime, in your career, there's only a certain number of patients that you're going to be able to treat. Right? So let's take transplant, because cataract obviously is slightly different volume, right? So even high volume corneal surgeons, for example, they'll be lucky if they do basically 150, 180 transplants a year, right? And so then if you basically times that over a career span of maybe like 20 years, right, for example, right, you're then talking about maybe at lucky 10,000, right? 10,000 patients if you're lucky, right? And then you then think, okay, for me working in Singapore, they have to be probably from local population, or they have to be wealthy enough to fly into Singapore, have their surgery done by me, and then stay there for a certain time. So you then realize, actually, this is great for the people who have access to a certain surgeon, but in reality, you've got to think about this much more globally, right? And if we think about this from a larger viewpoint itself, only about 1.7% of the world population have even access to tissue. Many patients still don't get to do, say, for lamellar transplantation, for example, because it is a difficult surgical procedure. I've been teaching it for like 15, 16 years, and people still can't do it because the volumes have gone down a lot, and it is difficult to do. So in reality, the more people that benefit, I don't expect everybody to be sending the patients to me to do, but if they can do it in their own centers, and that's one of the things, having fellows that have gone back to their own countries and then done surgery, it's great because it's not like me doing the surgery, but it's kind of like I taught this guy is then doing on a patient, say in India, Pakistan, the Middle East, UK, or wherever, Australia, but it's kind of like the patient is having the benefit of me teaching this guy, the guy then doing the surgery on the individual itself. So it's kind of like influencing way beyond that chance of that person ever meeting me is basically zero. But they don't need to meet me because they have the influential effect, and it's passing on to other people, this effect. And actually that has much more profounder effect in the bigger scheme of things. And one thing about transplantation, because the numbers are not like cataract, for example, the problem is that if you do not try to, you always at a status quo, right? Just because I can do the surgery, or I can do lamellar surgery, dog surgery, and we do a lot in Singapore, it doesn't mean everybody can do that. And that's where publishing, looking at research, looking at outcomes is very important. And what our papers basically have shown there from outcomes from lamellar surgery, for example, is showing you what is doable at a top center by people doing a lot of this kind of surgery. But real world is really important to understand. And we have to be quite, thinking about this. How can we translate this to real world medicine? Because that's going to have a bigger impact. And automating steps is basically real world medicine, because what that will do is, I'm not saying that you take things completely away from the surgeon's control. We're all doctors. We spent many years at medical school and residency in ophthalmology, so you need to have that control to understand what you're basically doing. But by automating the steps, it makes it much more systematic to achieve the ultimate outcome. And all of us want good outcomes for our patients. That's the ultimate aim itself. How we're going to basically achieve that is basically through automation. And one thing that automation does is it reduces the learning curve, right? And so that, you always have this thing when you were a resident, I was a resident, you have these senior professors around you, and they will tell you things, or they're talking from eminence and experience, right? And you can get that through automation. Right? Because you're basically reducing that curve down. You cannot wait until we're in our 60s or something like that. Think, okay, now I understand how to do this. But if we have a way of doing this in a way that it's basically safe, and with technology now advancing so much, basically over the last maybe 10 to 15 years, that's the advantage of basically automation. And then everybody, not just my patients, not just your patients, everyone's patients, whether in South America, North America, Europe, Africa, can get the same results as we're getting basically for our inpatients as well.
Right. And so basically what you just said is that automation is kind of giving you a chance at having an excellent surgery with lesser learning curve for the surgeon and in more percentage of patients.
That's right. Yeah.
So if you look at things from this perspective, like automation basically leads to more predictability. For you, for a person who's a prolific surgeon, does it allow you to push your boundaries also further?
Absolutely. So that's the big thing, right? There's always, you generally will have, and I think medicine unfortunately has these like generally two types of people, because generally doctors are not big risk takers, right? Because at the end of the day, we have patients, and you don't want to give nobody wants to give a patient a bad outcome, right? I mean, none of us want to basically do that. But you see, the thing is, I think my dad was a doctor as well, and I think that, me as a different generation cannot be getting the same outcomes as my father. I mean, there's no evolution then, right? Because we're getting the same things from there, getting the same outcomes. So you have to think, okay, how can we do better, or what is the better, right? If we're at 90% outcomes with a certain procedure, how can we get that to 95 to 98% outcomes and stuff, right? If you're an individual having a surgical procedure, right, and I say this to a lot of refractive patients as well, so much more so than even transplant patients. If I tell you there's a 90% chance you're going to do okay, now that sounds quite good, but it's not very good if you're in that 10%.
Right.
Because I'll say to you, hey, look, I'm really sorry you didn't have a good outcome, but don't worry, hey, 95 of my patients had a good outcome, so, you should be happy for me, right? Because 95% are good, but unfortunately you're in that 5%. Yeah, okay. So that's the difference between understanding means and standard deviations, right? And what automation and trying to basically reduce that down is reducing your standard deviation of an outcome. So it doesn't matter that basically you can be an outlier. Now, we're never going to be at 100%, but even if you get on an airplane now, it's not 100% that you're going to basically get to your thing. It's close to 99%. So as a medical fraternity or as ophthalmologists, so it's definitely for refractive, and I think you can apply this to many of our work that we do with cataract and also with transplant. We need to use like the airline industry as our standard, right? If you go on a plane now and say you're flying basically out of Delhi and stuff, and if I say to you it's 98% chance you're going to land in Singapore, yeah, okay, it's not that great because there's a 2% chance you may not make it, right? So then you're going to think, well, hang on, I'm not sure about this, right? And then you're going to have some doubts. Yet we accept 97% of our patients may get 6/6 outcome, and we think we're doing quite a good job, and we think we're okay with that. So we always have to evolve, right? And basically you always have to see, okay, how can I push the limits itself safely in a safe manner? And that's where innovation through research, innovation through technology, innovation that, you know, of being able to get that barrier, basically push that barrier further. And then there's always, you know, first mover people, some innovators in our field will want to try to push the barrier, and they'll, you know, push it up a little bit. And sometimes things get a little bit worse before they get better. We've seen that quite regularly as well. And that's where the science, or trying to understand the research to help us push these things forward itself, comes through. But generally, we have to then always try to see how we can push things forward. And the fact that, you know, 7 out of 10 surgeons getting an outcome, or 75%, may be good enough to pass a school exam with an A, but it's not it's not good enough really for most patients. And if you're in that unlucky 1% or 5%, yeah, okay, there's no point telling people that, you know, don't worry, 95% of patients are seeing well, but unfortunately you're in that. And that's what I think is really important for people to understand.
So basically what you're saying is that for a average surgeon or for a beginner, the results start getting better faster, and for a veteran surgeon like yourself, you are able to give more patients a predictable outcome than you would have given without the femtosecond laser or without the automations. So that brings me to my next topic, which is basically lenticule surgery. So lenticule surgery is a thing that cannot be done with a manual procedure. Like there has to be a femtosecond laser, which is basically the robot in ophthalmology, as we call it, that has to make the cuts. So how do you see lenticule surgery as different from LASIK? Do you think it has any benefits over LASIK for the patients?
So I mean, so LASIK is a great procedure, and I think there have been millions of people who've benefited from LASIK as well around the world. And to be fair, probably more though than any surgical procedure, has never been scrutinized as much as LASIK, as to be frank as well. And you know, it's fair enough, because our bars have to be very high, because of course these people can basically see quite well, obviously with glasses, or you know, without with some sort of refractive correction. But one of the things about refractive surgery, I mean, initially, I remember when I started doing refractive surgery in 2006, 2007, when I joined faculty in Singapore, I saw this patient, this girl, a Pakistani girl actually, and who was about 20, I think it's 22 years old, and she came in, and she was like -10, right? Now, we don't get many people who are -10 in Singapore, in London, for example. And she came for consultation with her mother, and in fact, it was very funny, because her mother basically was talking to me the whole time. She never really said anything at all. And she was -10. Anyway, the choice basically at that time was basically do ICL. Basically, this is like I think 2007. So we did ICL for her. And then, you know, she went from, you know, she got very good results. She was 6/6 basically unaided in basically both eyes. And then she came back. So I was following her up, you know, for normal clinic follow-ups to ICL. So she came back. And then over the years, I see her like once every like 2 years now to just do some measurements and of the lens vault. And I've seen her, you know, go to school, graduate with a degree. She came back with her partner. She got married. She basically, you know, they got a child. And I've seen this change over like 8 years, right? And at that time, I was like, well, you know, I do transplant. Everybody knows me as doing a famous transplant surgeon. Should I basically be doing like refractive surgery? Because, like, you know. And then I remember her saying to me that, you know, she said, you will never understand the impact of going from -10 to 0. Right, because you're not -10. I'm not, you know. So she said, Jod, you'll never understand that, and the effect on people socially and how they interact with individuals is tremendous, right? And even, you know, my wife has had lenticle procedure. I did for her because everybody refused to do it for her, so I had to do it for her. And again, she would say the same thing. I mean, she's not -10. She was like basically -7, -8. But the impact on the individual is really important, and it's difficult for us to understand that. But you see, one of our caveats of being doctors is to improve people's quality of life. That's what we all basically signed up to do. Make sure they weren't sick, make sure they basically can get them better, and basically now improving quality of life. And this has become more important now, obviously with an aging population now, right? As we're getting older, you know, there's in most countries, getting to 80, 85 years old. I mean, the average age in Singapore now is 87, 88. Japan is like, I think now 89, 90, right? So it's not difficult to get to live until your 80s and stuff, or 85.
Right.
Most medical systems will get you there. But quality of life is a massive thing. And if you don't have the quality of life of being at 85, 90 years old, then,
there's no point.
There's no point, right, to be fair, because nothing is going to basically be able to get these years. So, from a holistic point of view of treating the patient as opposed to treating their eyes, it's really important to look at the effect on the quality of life. And one of the advantages of lenticle procedures over LASIK, and we showed this in our RCT, where back in 2013, 2014, when I started doing lenticle procedures, in those days people never heard of it. Everybody's heard of LASIK. You go, if I go to Connaught Place or Delhi, you ask anybody, have you heard of LASIK? Yeah, everybody's heard of LASIK, right? But nobody had heard of some lenticle procedure.
In fact, in my practice, patients come to me and ask for LASIK. And then when I tell them that, this is a lenticle procedure, they get it done, and then they get their siblings or their friends, and then they again tell me that,
they had
you do the LASIK because you did LASIK for me.
Yeah.
And I tell them, LASIK is a flap-based procedure. Yeah. I did a flapless surgery for you, but the name has stuck on.
Absolutely, yeah. So people. So what we used to do was we do these forums, public forums, and then what we do is we used to talk about refractive surgery, surface ablation, LASIK, and at the end we say this is something new, blah, blah, blah. And then we used to introduce it in that way itself. So that RCT is very interesting because it's one eye LASIK, one eye lenticle extraction. Yes. So when we started the RCT, actually I can tell you it was very difficult. Nobody wanted to have lenticle extraction. Right. Even though we were pretty sure the results were very similar, nobody wanted it. Everybody wanted to have LASIK.
Right.
And when we finished it, like basically 2-3 years later, everybody wanted to have lenticle extraction. Nobody wanted to have LASIK. So it showed you how it basically had changed over this time. Some of the key things that we learned, and you need to have evidence to basically say this itself, right? And one of the key things that we learned is that you just, a lot of people, you're talking about young population, right? So when I mean young, so people in the sort of 20s, 30s, 40s and stuff, right. And even extend basically like mid 40s, late 40s as well, right? A lot of people are doing a lot more activity. Also since COVID, people are having a little bit more life thoughts about their quality of life, right? We all went through COVID pandemic and it affected us mentally as well in that way. And, people like not having a flap procedure, right? Because of the fact that they're doing more activities, they're doing more adventurous stuff, they may be doing like any water activities, scuba diving, whatever. And they're reevaluating that itself. And any minor trauma, even though I know the risks are small, it has to be a direct injury, but obviously with no flap, it is basically zero. And anybody understands that. Micro incision, no flap, it applies to the eye, it applies to your appendix procedure, it applies to anything that you basically have done. And people like that as a concept, small incision, micro incision surgery. So that's one thing that I think people like. Other things that came out was, everybody will tell you, anyone in the past that had LASIK done, they'll tell you that everybody gets dry eyes, right? We don't even say we don't say it's a complication because it's a side effect of the procedure. Right. It's just going to happen, right? We know that. Right. And the recovery of the dryness with the eyes, the amount of drops you have to put in, the stability basically afterwards, that's one of the things with lenticle procedures is much better than with basically LASIK. So how does that work for us? Well, because we do a lot of stuff, everyone does stuff on computers, right? They're always using the computers, they're always using basically screens itself. Right. People forget to blink, they get dryness in their eyes, they had to put drops in initially, but that recovery is important to them because most people are doing jobs now, occupations, where they either using a desktop computer, iPad, or some electronic device, right? As well. And also, people are working in some jobs longer now. So when I mean that, maybe into their 40s, 50s, they're retiring later, and they're using we use a lot, anyone doing any social media activities is going to have to use some electronic device itself. Right. So with that, you need to then make sure your ocular surface is well healed, well basically, has good nutrition, good tear film. And again, your nerve regeneration is superior with lenticle procedures compared to LASIK. So these things are kind of like measurable differences. Would it affect the visual acuity result? Maybe not, but it affects the individual as a patient. So that's again looking at the patient holistically, as opposed to saying, well, you're 6'6" on the chart, you can read this thing, okay, thank you very much, you can go and stuff, right? So going beyond just refractive correction, I think is important as well. Other things that basically we were able to show was more stability in the refractive correction, especially for moderate to higher degrees of myopia. So overwhelmingly, and this is a very unique set of patients, and I've seen them back now after 5 years where we've done some imaging for them as well. And the main thing is that they're much more stable, especially the moderate or higher degrees of myopia, compared to our equivalent LASIK patients. And if you look at people who are unhappy after LASIK itself, regression of their refractive error or refractive error coming back is a big issue for them itself. Right. Now, again, we're talking about young people. If you knock off maybe half a diopter, 0.75 a diopter of your correction, it's enough to drop you down from the legal limit of driving. Right? So it can have a profound impact on somebody's life there. Right. Then you have to think about, can I go for enhancement? How am I going to go retreat? So these things then come into the discussion a little bit more with the individual.
That becomes
itself.
More complex.
Absolutely.
Then.
So it goes there.
So basically, to basically put it simply for our audiences, what you said is that when you started doing lenticule procedures, you did actually a study wherein a patient had LASIK in one eye and lenticule surgery in the other eye, and lenticule surgery at that time was fairly new, so everybody was skeptical. But at the end of surgery, the outcomes were such that in the lenticule eye, it was doing better. So everybody wanted to shift to lenticule surgery and stop doing flaps altogether. Yeah. Now, I understand, we all understand why that happened. That is because there was lesser dry eye, the eye was safer, virtually 100% safe. So basically, it's after a week or so, it's almost as safe as not being touched at all. While in a flap, there's always a risk that it can get dislocated with a trauma, with an injury. It has some amount of dry eye which stays with you for a very long duration. So your quality of life is better with a lenticule surgery. Now, there are a few things that keep happening. New softwares come up for different types of treatment profiles in LASIK and everything. So looking at the patient's lifestyle, like you said, we are not treating the spectacle power or the higher order aberrations. We are treating the patient and his lifestyle. So if we are treating the patient and his lifestyle, what do you think is important? Is all this buzz about, a new software for higher order aberration correction more important in the general population? Or is having less dry eye and no flap more important? Yeah. This debate keeps on rekindling every 2 years because a new software would come up and say that this is even better than the before.
Yeah. So I would say that as a doctor, it's important to understand what the differences are when new things come around. I think that from a patient point of view, whenever we see new patients, for example, coming for refractive surgery, right? So during the history taking, it's just as important to find out occupation, sports, hobbies. This is a lifestyle. They basically, what is the individual going to basically have. So I can give you a scenario. There's a guy that I saw, a man in his, I think he's in his 60s now and stuff. Anyway, so he had tritium surgery 3 times, right? And done by somebody quite well known in Singapore. Then he came to see me, and then he said he had a recurrence and stuff. So I said to him, okay, this is what we're going to do. And he had scarred from all the grafts done previously. So I said, look, this is what we're going to basically do for you. Anyway, and then he said, okay. And then he said, so what are you going to do when it reoccurs? And I was like, well, it's not going to reoccur. And he goes, no, but this is he goes, Jod, this is my 4th operation, right? And I said, I know, but I said, it's not going to reoccur, right? And he goes, all right, fine. Anyway, so I did the surgery for him and that's about 9 years ago now that we did. And it was very difficult to do with the membrane graft. Anyway, so his family, he's got 2 daughters. One's a lawyer, one is a doctor. Yeah. The lawyer is married to a doctor.
Right.
Right? So, anyway, I did his surgery for him, and then he came back, and then so then one time then I was in clinic, then his daughter came, the lawyer came, right, and I'd given a talk on lenticle procedures. She came in, and she was seen by my fellow first. My fellow clocked her, and she comes to see me, and she goes, "Don't touch this girl, right? She's very difficult, and she's super, type A personality. Don't touch her, right? Don't touch her." But when I spoke to her, she said, I had a long chat with her, and I said, look, these are your scans, this is the thing itself. Her posterior flow, when I examined her, wasn't quite right. So tomography, not quite right. She wanted a lenticle procedure because she'd seen it and those things. She 100%. And I said to her, look, I had a look at the scans. I said, look, I'm not going to do this because I think I said, we're going to do refractive surgery. I think she was -3, -4. You're going to do refractive surgery, we're going to do advanced surface ablation for you, right? And she goes, okay, I insist that you do lenticle procedure for her. And I said, I'm not going to do it. I said that you can go to, like in Singapore, we have Orchard Road, it's very famous, like shopping market, there's a lot of private clinics there. I said, you can go to Orchard Road and you can get somebody who I taught how to do the procedure to do it on you, but I'm not going to do it. So, right. So then she thought about it, and so then she came back and she goes, okay, fine, I'll go for surface ablation. Okay. So anyway, what happened was when I did the procedure, she cried so much. It was unbelievable. I mean, if I'd done lenticle, she would definitely had suction loss. I mean, no, 100%. Anyway, you know, she comes in the next day, I'll never forget, with her mother in the clinic wearing dark glasses and stuff. And she came to the clinic as if she was walking as if she was practically blind. And I was like, oh my God. And then, you know, she came in and, you know, her mother, very patient, came in with her. She sat her down and she had a look. I said, everything looks fine. It's good. This is what you're going to do. We take the lenses off after 4 days, and then this is going to heal. Anyway, her husband, who's a doctor, I saw him, and I saw her sister, who's a pediatric doctor and stuff, right? Yeah. And he's in neurology. So she came in, his sister came in to see me, -5, -6. She does like hot yoga. She's quite a bit more relaxed, but you know, she's medical and stuff, so she's worried about her eyesight. She doesn't do surgical subspecialty, but she's worried about her eyesight and stuff. So I saw her and I said, okay, you're going to do lenticle procedure for you. It fits in with your lifestyle. She was worried about the fact how fast she can get back to yoga. She was worried about the fact that she does some like contact sports as well. So she's worried about some injury and things for the eye. So she said, look, you know, Joe, when can I get back to my lifestyle? When can I get back to my quality of life thing and stuff? So I did basically lenticle extraction for her. The husband, basically I had a look at him, I did LASIK on him and stuff as well. He does no contact sports. Most of his stuff is basically involved with reading, and you know, he doesn't really do, I mean, he was a resident, he was doing his exams and stuff, no contact, he's not really into sports and stuff as well, so he basically opted that. So I think that, you know, in one family, you see 3 different procedures. They all ended up with excellent outcomes, right? Basically, at 3 months, I don't see them now, but they're all basically either 6.6 or better in every single eye. It's half of the eyes are 6.4.5 from 3 different surgical procedures itself. But the point I'm trying to say is that for that individual, that was the appropriate procedure. And I think that, you know, it's important that obviously excimer technology improves, because there is people who will basically need to have that, because of course, you know, we can still use lasers. And likewise, again, it's about reducing the standard deviation. If you look at the population, you know, we can draw these bell curves for normality, but you see in any bell curve, there is always 2.5 above and 2.5 below, and 5% outside the bell curve, right? Or 95% confidence itself. And that's where you may need to do something else on that individual, whether it's a topography guided profile, you know, or doing something else with an excimer laser that we currently can't do. Maybe in 10 years time, if we have this conversation, maybe we'll be doing topography guided lenticles, I don't know. But currently we can't do this itself. So it's important to be aware of where you can put that technology into your individual. So majority of the patients, sure, they were basically doing fine. You don't need to have necessarily more advanced things itself from there. But, you know, that's why I'm very skeptical about vision results, because, you know, you can go into a room to test your vision, which is a high contrast screen, black on white, right? Put drops in your eyes and read 2016 on the chart, right? But that's not real life. Right? That's not like driving a car or using your computer for 2 hours and stuff. If you have to use your computer and you having to put teardrops in your eyes all the time, right? You tell me how that person's quality of life will be. But yet, from a chart point of view, you're actually seeing quite well. So that's the difference between looking at a refractive outcome and looking at a quality of life outcome for the individual itself, right? And so that's why I don't think one thing is better than the other. I just think that it's nice to have all of these things available.
So, sir, to put it more simply, because I know you put a very nuanced perspective in front of our eyes, like we should have everything in our armamentarium and we should pick and choose for every patient. And in fact, we have had a very similar experience, you at the peak of your experience and me at the beginning of my career. I have had family members, like two of my sisters underwent a advanced surface ablation, that is trans-PRK, and one of them had a LASIK, and then 2 of them had a lenticle surgery. So like all of my sister-in-law, brother, whole of the family has undergone refractive surgery, and all of them have had different procedures, and all of them have been done by me. So I completely agree with you. what I want you to simplify for our audiences is that in today's world, if all of the three options were there available to me, with the kind of lifestyle that we are living, with computer screens in front of us, we want quicker recovery, safer surgery, how many patients would be undergoing clear, and how many would be undergoing surface ablation, and how many would be undergoing LASIK for the different criteria, notwithstanding the corneal thickness or the maps as such?
So I mean, I when I see people, I keep surface I keep as a reserve procedure for who cannot have either LASIK or clear. Right. And I tell people about it because you can look it up on the internet and you can read about trans-epi PLK or basic surface ablation. But I tell them I'm not going to talk about this because you can have one of these two, and mainly because exactly like you said, it's the speed of recovery. I think it's a great procedure, but it does take longer to recovery regardless of anything. And people, that's important for a lot of people to get back to work or get back to their lifestyles and stuff as well. So that's going to be a smaller proportion of patients because I automatically would exclude them if they can have one other procedure.
Right.
When it comes down to then LASIK and then clear itself, again, with once the patients have been clerked on this thing itself, generally I tend to do more clear than standard LASIK, mainly because of the fact that I can normally pick up something in whether it's dry eye disease, whether it's basically long-term contact lens, where that is going to basically affect the ocular surface recovery, something in their history or something, whether they're doing contact sports, something in the history itself that will then tell me, okay, I think you should have this. They say to me, why do you think this? I said, this is the reason why you can have. It may only be one factor, right? But it may be something in there. I'll tell you one anecdote. I saw this girl, maybe about 2 years ago, who had LASIK done 10 years ago. My kid, a long time back and stuff, right? But she had done when she was 22. She's 32 now. And the reason why she came see us is because she had a baby, right? So what happened? So she was holding the baby, and the baby's finger went into her eye, and can you believe it? After 10 years, it dislodged the flap. Right. And then we were chatting. Anyway, I managed to put the flap back together for her, and then she had epithelial ingrowth and stuff. We had to clean the flap. The whole flap was transected and stuff, and eventually basically settled down once the epithelium went there, and I didn't have to do any treatment for her. But we were chatting about something, and she said to me, if I could have had a lenticle procedure done then, I would have done it. I said, well, back in those days, it wasn't around. I think it was 15 years ago she had LASIK done. I said it wasn't around, it wasn't there itself. But you see, at that time when she was 22, it might have been the option. But of course, she thought sometimes she's probably going to get married, sometimes she's going to have a baby. So these things, but you could never predict your baby's going to hit you in the eye. But it could happen, right? I mean, you don't know, right? And stuff. But children put their hands everywhere. So in that way, you see, people are thinking, well, hang on, is it safe? And honestly, I think a lot of people like the flapless concept, and I think that's a real advantage for many people.
That's true. Because when I tell my patients, I always tell them with clear, you are as safe as being untouched. So you can go about your life carefree. With a flap in there, there's always that 0.1% chance that tomorrow you land up in something that damages you get a trauma, or you get an injury, or you are in a situation that makes your eye go worse than what you used to be. So and that may not be always repairable. Sometimes you can land up with some kind of a complication that I cannot completely correct. So that's why lenticle surgery gives you that freedom, like after the surgery, after your 4-5 days of whatever recovery is there, you are back to being your normal self. Your eyes are really, with LASIK, I always see those little bit of puffiness in the eyes, some swelling on the next day. But with lenticle, with clear, this almost always, like, I'm looking at the patient and I'm wondering when they underwent the surgery. Like, it doesn't even take 24 hours for the eyes to look absolutely normal. Looking at lenticle surgeries as such, the quality of vision is one aspect that people talk about. They say that LASIK has a day one wow, and clear or any other lenticle surgery does not have that much of a wow effect. What's your take on it? How important is it?
So it's interesting because most of the time it's very rare that patients will have two different procedures. right? Where you can actually say, one eye, say, had LASIK, one eye smiled, like our trial, right? When I saw those patients, I mean, out of the 70 or something, 80 patients that were in the trial, I did like 75 of them or 79 of the patients. So I did most of them and stuff. And when you look at the day one vision, if you ask the patients, is there a difference in the vision? And you've got to understand, this is back in 2013. So it's not 2025 lenticular extraction, it's 2013 lenticular extraction, right? So we've learned a lot about instruments, dissectors, energy settings, a lot over that time period. Most of the patients tell you the vision is the same.
Yeah.
Right. And these patients actually had different procedures.
Right.
When I looked at it if you look at it numerically, for example, looking at visual acuity data, I can tell you just anecdotally that if the LASIK eye was 6.6, the lenticule eye was about 7.5, right? If sometimes it was the same.
Right.
Okay, but you got to, like I said, this is 2013, 2014 when we were doing lenticular extraction. If the lenticule eye was 6.6, the LASIK eye was 64.5, right? But that's us checking on a chart. But when you ask the patients, they never told us this.
Right.
They never said this, you see. And I thought that was quite interesting because they never actually noticed the difference. And you've got a very unique data set. In reality, most people are never going to be in those kind of studies and stuff because most people have the same procedure on afterwards in both eyes itself and things. And I think that now when you're talking about, so lenticular extraction 2025, it is not the same as lenticular extraction in 2012, 2013 and stuff. And I think with the improvements in the laser, with the improvements in basically the energy settings and the optimization energy, what we've learned with the dissectors, nowadays, I think the majority of the patients, I would say probably quite confidently, I'd say over 90% of the patients are basically going to be 20/20 within either day one or within the first week, basically after surgery. And most people will accept that. I think it's not those days of in the past when people were so far out from being close to LASIK. So I think that wow effect there, I think is a little bit historical. I think that, again, even at meetings and stuff, often people will show papers from 2013, 2014, but that's like almost 11 years ago now, right? So it's important to also see that the technology has changed over that time period and not, anything that, from 10 years old is different to what we're doing now.
And so when you said about the evolution of technology, how did Clear change the lenticule surgery? Like, what all changes did Clear bring about that have changed the lenticule surgery and sort of taken it to the 2.0 thing,
So I think that one of the major disadvantages with first generation lenticle procedure was that the torsion control and the centration had to be done by the surgeon, right? And that was always going to be an issue, right? We know that because again, it comes down to how many people are going to be treated by one surgeon, and the advantage of refractive surgery is many people can have it and stuff, right? So you've got to make this equally access to many people around the world. So that needs to basically improve on. So I think we knew that, and I think that most of us knew that, and we knew that, and obviously we learned that from LASIK technology with the Ziemer laser, with the tracking and with the eye movements as well. So we know, I think that we knew itself, right? And having basically cleared the ability to centrate and now basically auto-centrate and rotate for torsional control is a massive advantage and stuff. The reason why, how that comes out in outcomes is that not only does it improve the chance of getting a good visual outcome with respect to, say, 20/20 vision, but what it does do improves the quality of your vision because you're getting less aberration. So patients, they may be 20/20, but they'll say to you, if I go outside at nighttime and I'm driving my car, when I see a light or a street light or the car coming on, I'm getting a little, stringing or a little obliqueness around the thing. So you're improving or reducing the chances of getting them induced vertical coma or coma from the lenticle procedure itself. And that's a massive advantage because what you're then being able to do is you're taking a little bit of the control out of the surgeon again. So it's coming down to automation with the laser process itself and then putting it back to the machine to basically automate that itself. So the surgeon feels confident, I can get the lenticle exactly where I want in the position that I basically want itself. And doing this not just for 5 patients, not just in patients coming to certain clinics, into every single patient that basically has the Clear software on the laser in every center. And that's really, I think that's a massive advantage of the new generation, second generation procedures.
So I think you really put it out there. The second generation lenticule extraction is basically kind of machine controlling the safety nets for you. So it's providing you with some safety nets, just like LASIK without a tracker would require the surgeon to always keep looking at the pupil, and whenever it would move, you have to stop your foot switch, and then you have to reposition the patient and fire again. But now with these advanced trackers and excimer laser tracking the movements of the eye, you can just put on the switch and micro movements would be taken care of. So my life has always been easy with excimer laser because I never had seen the lasers without a tracker. Same with clear. For me, I have always had the chance to center on the visual axis and always correct the cyclotorsion. So I've never even imagined that some surgeon would have to make the efforts or would have to redock multiple times just to center the lenticle on the cornea, and that's a paradigm shift that came, and that's why we call clear the next generation of lenticle surgery. So when was your first trial for clear that you did? Like, when was the second generation being ushered?
So I think we started in, I think I did some cases maybe 2017, 2018. That's when we basically started with the procedure. And at that time, you had the ability to move the lenticle across the screen. We used to mark the corneas, but you had the ability to move the lenticle then across the screen to the central point. But somebody who's come from a system where we have to do this manually you could immediately see, okay, this is a massive advantage from there itself.
So it must have been exciting.
Yeah. So it's absolutely, and I mean, and again, when you're looking at data, when you're looking at interpretation of data, review data, systematic reviews, basically show this from multiple centers around the world. Doesn't matter whether you work in China, India, Europe, it's showing the same data that there is this inherent variability in outcome itself. And I think by centering this down, where we're being the ability to do this, will definitely improve the outcomes.
Right. So moving on from refractive surgery, let's talk about cataract. And this machine, which is like small, smart, with a mobility, ergonomic handpiece, it gives you a lot to do with cataracts as well. And a lot of surgeons in their experience have seen that this low energy overlapping spot concept works very well with cataracts as well. Can you tell me a few of the points, the important things that are different in this laser, the Z8, compared to the cataract done on any other previous generation femtosecond lasers?
So I think that, we have to always bear in mind that the Ziemer technology has come from cornea to cataract. Right. So it's not that the machine is built for cataract surgery and then it happens to do cornea. So the reason why that's important to understand is because of the fact that the incisions, for example, are very good, because of course the LASIK and the clear is very good, right? So the machine can capably make good corneal cuts. So that's one thing. And many people, when they started doing femtocataract, didn't even make incisions with the laser because they were actually not very good, or they weren't in the appropriate place on the cornea itself. So they're basically just using the laser to do capsulorhexis and basically the fragmentation. So that's one thing which is a differentiating factor. So you're gonna get very high quality incisions with the Z8 doing cataract surgery. And then if you use it for AKs, for example, and things as well, your AK is going to be very good, because essentially the Z8 is a very good corneal machine because it's going to do corneal refractive surgery. So that's one thing. The second thing is that when you then look at the breakdown of the procedure itself, primarily you're doing two things. One is fragmentation, one is capsulotomy. Okay. The thing is that the reason why people were, most experienced surgeons can do cataract surgery quite quick. Obviously, we all learn how to do capsulorhexis, and we've got volume, so we've all done like thousands of procedures. So, you can do a capsulotomy quite well with the procedure itself. One of the studies that we did very early on was really looking at the capsulotomy in quite a lot of detail that's been cut with the Ziemer. Now, the Z8 offers some very unique features. When you're doing the surgery itself, the laser head is in your hand itself. And if you look at the laser head, it moves in two ways. So one actually does a rotation movement, and that's when the capsulotomy is basically being cut. And the second, when it's doing the fragmentation, actually the laser head is still, because it's flying on a vertical platform. So it's like putting one laser pulse on top of another laser pulse. That circular motion, this is the only machine that does that, actually produces a capsulotomy at the edge, which is very similar to doing a manual rhexis, because when we all learn manual rhexis, what do? We make a little cut, and then we do a circular capsular rhexis all the way around. And the laser is doing that, but at laser precision compared to the surgeon doing it by hand. And so that's something that basically mimics what we do. So it's the laser mimicking human nature, as opposed to laser doing something different. And then hopefully we're hoping that it's going to be close to similar results. How does that affect the surgeon? So obviously, we're still both young, so I think that we can probably do rhexis quite well. But I met a guy, who's like basically in his 70s, late 70s, he was going to retire. And then I asked him about, you doing, femtocataract, and he said, yeah, Jod, he says, I'll tell you something about laser. So he came to Singapore to celebrate his birthday with his wife, and then he came to SNEC to just watch some surgery. And he said to me that, one thing, I'll tell you something about femtocataract, it's extended my time of doing cataract surgery for another few years, because I feel confident that I'm going to get a good capsular rhexis and my incisions are good. And I never thought about it, because obviously you're not the same age, right? So I never thought about it in that way. And he said, he goes, I thought, well, maybe I'll stop doing surgery and stuff now, but having it, the femto, has now extended my time a little bit longer, and I think I can do it, be a little bit longer. The other thing with the rhexis is the strength of the rhexis is very good, right? And we've studied that both in pig eyes and human eyes, and shown you how good it is compared to a manual rhexis. So why is that relevant? Well, it's relevant because of the fact that now we have a whole range of different lens technologies. I use a lens typically for a lot of my patients that I can clip to the anterior capsule, so I can fix the effective lens position to exactly where I want. The massive advantage of that is that I know the refractive outcomes are going to be very good, because I don't get that variation within the bag placement. But even if you put the lens in the bag, having a perfectly symmetrical rhexis is vitally important, because of the fact that with capsular phimosis and stuff, as the lens will shift, you'll get non-axial displacement of the lens. Now, again, it doesn't matter if you're putting a monofocal lens in, but if you're putting any trifocal or bit more, let's just say, premium lens technology, if you're going to get a shift, it's going to definitely affect the patient's visual outcome. And you have to bear in mind, again, it comes down to the fact that we're in an aging population, people are living longer. Those lenses that we put in at 60 years old are going to stay in the eye for 28 to 30 years, maybe even longer, right? Nobody would have imagined that before, right? So I always tell people, if you think you're going to die and you have cataract surgery at 60 and you think you're going to die at 63, we can do anything, right? But if you're gonna basically think, okay, if you have surgery at 60 and you're gonna live until you're basically 85, which a lot of people are basically gonna do, that's 25 years of that IOL inside the eye with all the phimosis around that area itself, right? And if it's not a perfectly centered rhexis and things, right? And even the best surgeons, can have off days, or they didn't sleep well, or when they're doing the surgery, so it's not a perfect rhexis. But here, again, automation, every single rhexis is perfectly round, it's going to be in the right centration, it's going to be perfectly on the visual axis, so you're going to get this every single time. So then when you think about fragmentation, so you're looking at fragmentation, and there's new software now on the ZA to allow you to basically fragment the nucleus even more again. Some of the studies that we've done is basically by looking at taking aqueous from the chamber after the fragmentation from there itself, and we're able to show that with the ZA you can really increase, so having higher energy settings on the ZA, because it's a low energy laser, it's still way below, it's log levels lower than a higher energy setting laser itself, with respect to the effect it has on the aqueous environment with respect to oxidative stress. How does this affect our patients? Well, they get better cell counts on the endothelial cell count, because you get less oxidative stress even in these very dense and difficult cataracts itself, because you're going to use less effective phaco time when you're doing your basically surgery, because you've got that fragmentation. But going beyond that, you're going to basically reduce that down even further, because you haven't got a lot of active metabolites inside the anterior chamber. And that's one of our papers basically showing that effect, where we compared a high energy laser to a low energy with the ZA as a comparison itself. But it's only by looking at these things at microscopic level or molecular level that you can then start to tease out some of these differences, and saying, if I have a patient diabetes is very common, a third of the population is diabetic, they have higher risks of getting CMO, as we all basically know, and so maybe I should be using a ZA to basically do my cataract surgery, because my risk of getting CMO is less, because we're using a lower energy system rather than using a high energy system. So then these things become a little bit more important to your choice of laser?
In fact, in my clinical practice, because we get a lot of hard cataracts, in this northern belt, India, lot of sunlight, harder cataracts, diabetics. Diabetic hard cataract is something where I love to do a femtosecond laser assisted procedure. In fact, that is the only indication, or probably a subluxated cataract and a diabetic heart cataract would be the only two indications where I would urge my patient actively to get a femtosecond laser assisted cataract surgery done, because it eases my stress, it makes the surgery safer, and it definitely improves the patient's outcome. So I completely agree with you.
So in addition to that, I do a lot of patients who have Fuchs. So Fuchs, 100% of the time, I will always use a femto. And in Singapore, obviously, we have a very high Chinese population, so we have a lot of patients with very shallow anterior chambers.
Right.
And really, before you even open the eye, your rhexis is perfect, your fragmentation is already done. So what it does is it takes that risk out of the eye, with a shallow anterior chamber. You're doing your surgery, you can see the AC suddenly debulk back, and angle closure is very common in amongst Chinese populations, and those are massive advantages of using a laser procedure. And because of the fact that half the surgery is almost done there, because you've got a good capsulotomy, you're not going to have an issue with that, or the rhexis going out, because you haven't got the maintenance of the chamber, because everything's been cut for you before you've opened up the eye.
So to conclude, sir, you do a lot of variable things with the Z8. Some things which are still in research being developed, and not everybody has access to them. They are not routinely performed. Are there any surgeries that you've started doing which cannot be done by a blade or a human hand and can only be done with femtosecond laser? And is that scenario going to develop in the future as well? For example, like your DMEX, which you do after the ALKs.
So that's a very interesting procedure, because I'd seen, even when I mentioned it earlier on another talk today, that somebody said to me, I have patients like that as well, but I don't know what to do with them. And I saw patients like that for years before and thought, God, how do you actually handle this? And then when we had the idea using the liquid interface to cut from the inside the chamber up into the cornea itself, and then simply remove this through keyhole. It's simple in the concept, to be frank, but the actually way of actually applying it, and then to work out the fact of how to then put the DMEC into the graft itself, to me this would be impossible to do. It would be impossible to do, because any laser system that, as you know, when you're applanating on the surface itself, you get these folds in the posterior cornea.
Right.
The Ziemer has the advantage of having two interfaces. One is a liquid that we use for cataract, and then of course the flat one that we use for LASIK and smart and clear as well, and basically pockets and things, right? So using the liquid interface that doesn't compress the cornea at all allows us to really use the precision. And then of course we use the intraoperative OCT on the laser system to guide it. And somebody asked me earlier today, Jod, how do you know what depth to do? And I said, well, just use the OCT, man. It's just like basically, so you can have one patient, and again, in every 30 degrees the laser will measure the angle around, and I said the depth will vary, because you asked me what depth to use, and I said, well, I don't know, it'll vary from like 50 microns up to 120 microns, but you can just set it on the laser, because he thought I was setting it to a specific depth. I said, no, you just look at the OCT, and then we just tell the technician this is where we're going to stop, and then you can do that surgery. So that, I think, would be, to be frank, probably nearly impossible to do by hand, because not only are you cutting from the inside of the eye to basically go into the graft, you have to do it in a nice circular situation, because you have to put another graft there itself. So the matching has to be perfect, right, in that area. So I'm not even sure how you do. I've seen cases like this many times before, and I thought, I'm not sure how you could argue you do a penetrating keratoplasty, but of course we know the long-term issues with that as well is an issue. And that, to me, really shows the novelty of the laser system, to be able to do something like that, which it was never designed for, but that's the advantage of having a clinical application to a technology. So engineers or Ziemer may develop something, and then of course it's up to us as clinicians to see, okay, where do we use this in our practice? So it's not hundreds of patients, but I can tell you the people that have had it done just think it's amazing. I mean, I'm not sure they fully understand what they've had done and stuff, but they will tell you that, you know, they can see well, and that some people say to me, Jod, most of your patients have probably no idea of what they actually had done on their eyes. They just think, okay, they can see well, they had a great result, but the technology behind to do that, you know, is great to be able to see that to the individual. But again, it comes down as a clinician, we all want to try to get good outcomes for our patients, and by using that technology in a slightly different way to what it was designed for, we're able to achieve outcomes that were basically unthinkable when you to do it otherwise.
In fact, let's end it at this. When I saw that procedure happen, and it completely blew my mind, because being a cornea surgeon, I see corneal decompensations, bad corneas, not seeing properly day in and day out. I see failed keratoplasties every day. And then, I know the importance of an endothelial keratoplasty. And when I saw the procedure, it completely blew my mind. I was thinking that, this is so amazing. And when I explain it to any ophthalmologist as well, who's not doing endothelial keratoplasties or who's not seeing complications of keratoplasties as much, it's difficult to even explain it to surgeons. So I can totally imagine that your patients are living in the happy oblivion of not knowing the complexity of the thing that has happened with the Z8.
Yeah, no, it's great. Yeah, absolutely.
So I think that brings us to the end of this podcast. It was great talking to you, sir.
It's great.
Your insights are always very useful, and I'm so happy that we could borrow you from your busy schedule for this podcast. Thank you.
Thank you very much. Thank you.
Thank you.